Hello, everyone. This is Dr. Mlenga, a clinical sonographer, currently heading the Department of Diagnostic Medical Ultrasound, Lusaka Apex Medical University. Today's topic, we are going to look at one of the most interesting topics in echo, which is called left ventricular systolic function assessment. This is another important aspect of echo that we need to consider whenever we are performing echo. Remember, echo has to be done by assessing the function and also the structure part of it. So this is the function part of the echo that we are going to look at. And my objectives are very simple. I'm going to define what systolic function is. I'm going to define also what other methods we can look at when assessing this ventricular systolic function. We've got the TEC method. We also have the Simpson method. I'm also going to look at some of the echo parameters and views that we should look at whenever we are looking at this assessment of the left ventricle. I'm also going to look at the right ventricle systolic function. This is another part where sometimes we forget to discuss about the systolic function of the left ventricles. But typically, we also have to take into consideration that the ventricular function of the heart also takes into consideration the right ventricle systolic function. I'm also going to give a conclusion, and more importantly, I will also discuss this equation, which helps us to understand the ejection fraction, which says the ejection fraction is equal to the end diastolic volume minus end systolic volume over end diastolic volume multiplied by 100. This is another important equation that we need to know whenever we are calculating. We don't need to stress about where this equation comes from because this is embedded in the machine so that you can calculate. So what is systolic function? By definition, systolic function, this is a contractility of the right ventricle or the left ventricle chambers of the heart. Remember, we've got 4 chambers, the 2 atriums and the 2 ventricles. So the contractility or the contraction of the right and the left ventricle is what is termed as systolic function. And during this contractility, several things happens within the heart chambers, and the cardiac chambers also tends to have specific physiological function that goes on. And one of the most important things that is done is the cardiac output. And this cardiac output, we must understand that it has got parameters. And these parameters states that cardiac output is equal to heart rate multiplied by the stroke volume. This is a very simple equation, but this can actually affect how you can quantify some of the parameters that comes into play. But the reason I want to bring out this, we have to know that the cardiac output, the heart rate, and the stroke volume can actually be calculated within the echo parameters that comes into play. So we are going to see, once you have this contraction of the left ventricle and the right ventricle, what really goes on. And one of the parameters that we are interested in is the cardiac output. Not only that, we are also going to see that this ejection fraction is nothing but the volume of blood that is ejected out of the left ventricle per minute. And this is very important again to consider. Not only that, there are other parameters that we are going to see and the methods on how we should prefer to actually quantify the left ventricle systolic function. There are a few things that you need to take into consideration whenever you are discussing left ventricular systolic function. And I'll start by mentioning the method that are currently being guided and the current method that we need to use. And the first method that we use is the biplane, or rather the TEC method, where we use the M mode. And the second one, this is the type of method where we use the Simpson method. This has to take into consideration the volumetric aspect of the right ventricle. And it also becomes very key when you have certain pathologies that may affect the myocardium of the heart, so that you cannot use either this one. So the preferred method, when you have some regional abnormal wall motion, we actually use the Simpson method because it's not affected by the systolic thickening or the contractility of the left ventricle. So this is a biplane which we can use. Preferably, you don't have any abnormal wall motion. So this is what we normally use, the biplane. This is the biplane, the biplane method. So this is where we need to use this parasternal long axis view, parasternal long axis. So this is how you are going to have, your parasternal long axis there. This is your parasternal long axis. Then you are going to have that. So remember, there are three measurements that you need to take whenever you are taking your parasternal long axis. One, you take it right at the aortic valve. The second, you take it right at the tips. And the third, you take it right at the left ventricle. Remember, this is your septum, the IVS. This is your left ventricular posterior wall. And then you've got the tips. These are the tips of the mitral valve leaflet, both the anterior and the posterior. So, and then this is your aortic valve. So once you pick this view, you are going to have, remember, there is something that is going on at septum and also at the posterior wall. So during systole, remember the cardiac cycle and the timing of this cardiac cycle is measured by M-mode. So the best modality to use to quantify this is the M-mode. So you are going to have something like this, which is very, very important. Sorry. You are going to have something like this. So what you are going to have is this. You are going to have this. Okay, you are going to have that. Okay, so this is your septum and this is your posterior wall, the left ventricle posterior wall. So this is contraction. This area, this is contraction, this is relaxation, this is contraction, this is relaxation. So the cardiac cycle and the timing is going to be measured by the M-mode. Remember, M-mode helps you to measure the cardiac cycle and also the dimension. So we are going to see the dimension and also see the cardiac cycle. So this cycle continues from one point to the other. So during systole, this is what you are going to have. And during diastole, this is what you are going to have. And remember, I said ejection fraction is calculated by the end diastolic volume. This is the end diastolic volume minus the end systolic volume divided by end diastolic volume, and it's going to give you your ejection fraction. So you need to understand that this ejection fraction has got a lot to do with the contractility and the relaxation of the left ventricle chamber. And why is it so? Because we are basing so much our calculation on the contractility and the relaxation of the left ventricle. So one thing that is very important is to consider the systolic thickening. So this is what we call systolic thickening. During systole, the left ventricle or the septum thickens. You can see there's thickening here, which is evidenced by the reduction in the chamber. This is your left ventricle chamber. This is your IVS, and this is your left ventricle posterior wall. So more importantly, you need to know the normal thickness of the IVS. You also need to know the normal chamber diameter, internal diameter, both in systole and in diastole. You also need to know what is the normal thickness or normal measurement thickness of the left ventricular posterior wall in systole. So typically, the septum during diastole the normal measurements should range from 6 millimeters to around 9 millimeters in females. And you can also have 6 millimeters to around 10 millimeters in males. While the left, this is for the IVS in diastole, internal diameter, the thickness in diastole. And then you can also have the left ventricle internal diameter. This ranges between 3.5 to around 5.6 centimeters. Or you can use 35 millimeters to around 56 millimeters. This is regarded as normal in diastole. This is particularly for the left ventricle internal diameter in diastole, which is the distance from here up to there. The distance from there up to there, this is in systole, left ventricle internal diameter in systole. So this and that, this is what we are pushing into the equation, and these measurements are very important. Remember, echo deals with very small figures, and wrong technique, wrong measurement can result into the wrong diagnosis and consequently wrong treatment. So I'm trying to emphasize these points because these can actually mislead your technique whenever you are doing these measurements. So I want to emphasize the point that make sure you are perpendicular. Make sure you are perpendicular whenever you are picking this parameter in the biplane. And once you pick this one, this is what you are going to have. So after you do your calculation, that is, you measure your left ventricle internal diameter and the posterior wall and the thickness, the machine is going to automatically calculate your ejection fraction. So this is how you start. You start with your intraventricular septum in diastole. So you measure and make sure your measurement is very accurate. You measure from there to there. This is the thickness in diastole. You measure it in diastole. You measure from there to there. And also you measure the left ventricle internal diameter in diastole. So once you pick that one, you are going to measure from this point to this point. Again, you measure, this is the posterior wall. This is the left ventricle posterior wall, which should also be in the same range with the septum. It should also range between 6 millimeters to 9 millimeters in females and also 6 millimeters to 10 millimeters in males. So this is what you are going to have. Once you calculate the measurements or the diameters in diastole, you also have to come and calculate also your measurements in systole. But how would you tell this is systole? This is systole, this is contraction, this is diastole. This is systole, this is diastole. No wonder this is called the systolic thickening. Systolic thickening. So when you come here again, you measure your septum in systole. You also measure your left ventricle internal diameter in systole. This is now in systole. And once you calculate there, you also come back to your posterior wall in systole. You are going to see that this and that, this and that. You are going to do 4 measurements. And these four measurements are going to give you the ejection fraction. Automatically, you are going to see it coming just across your screen. And this is how you measure your ejection fraction using the biplane. It's very simple and straightforward. All you need to take into consideration, make sure that you understand your technique, you understand your planes, and you also understand that it's not being taken at an angle. So it should be very perpendicular and not picked like this. This is a foreshortened image, and I don't encourage you to take these measurements at this plane, or you do it at another plane like that. So make sure you pick it very perpendicular to the left ventricle so that you have the correct representation of the left ventricle internal diameter and the correct representation of the left ventricle internal diameter in systole. This is preferably when everything is okay, you don't have the abnormal regional wall motion. But the most preferred method is the Simpson method which is also takes into consideration the volumetric function part of the left ventricle, and also it's also preferred when you are having regional abnormal wall motion, where you may not appreciate the systolic function and the diastolic function. For example, when you have this compromise, this systolic function is compromised, your preferred method is to go for a Simpson method. So once you calculate your ejection fraction, you must know the normal. Standard normal ejection fraction by American Society of Echocardiography, the current one is 50% to around 75%. This is regarded as normal ejection fraction. Other guidelines or literatures, they also give you things like 55% to around 70%. So both of them currently, they are some of the current guidelines that we are using when it comes to the normal ejection fraction. The other parameter that is going to also come out here is the fraction shortening. Fraction shortening is also the contractility. Okay, let me just show you. So fraction shortening or the FS, it's abbreviated as FS. So this is the contractility of the myocardium. It's also automatically calculated by this method that we are using, and the normal is going to give you 25 to around 45%. So these two parameters, the ejection fraction and the fraction shortening becomes very handy when it comes to the quantification of the left ventricle systolic function by biplane method. So these are the methods that you use. One of them is the TEC method, where you use the M-mode dimension. So this is the method. It's also called the TEC method principle. We are going to look at how we can use the biplane method. So the biplane method, it's also very simple. You just need to take the preferred view in the biplane. So the preferred view is apical window, where you can have something like this. You are going to have your heart, your apical four-chamber. Then you can have also so this is very important when you are using your modified Simpson. So this is the Simpson method. You have your left ventricle, your left atrium, left ventricle, left atrium. So once you can either use a two-chamber view or you also use the four-chamber view. The principle should be that these are the mitral valves. This is during systole, they are closed. Make sure they are closed. You open, you close your frames, and then make sure in the other chamber the mitral valves are open. This is the first consideration you must take note. Take note, one, you take it in diastole. Diastole simply means your mitral valves are open and the aortic valves are closed. And this is in systole. In systole, the mitral valves are closed and the aortic valve is open. Remember, you can actually see them together. And then you go into your protocols, cardiac protocols, you pick whether you want to use the 4 apical or the 2 apical. The 2 important things is one should be in diastole, one should be in systole. So you come to this one, you trace, depending on the ultrasound setting of your machine. Others you can trace, others you can actually do a biplane and it calculates for you. So you can use this. So if it means tracing, there are some few considerations that you need to take note. Number one, make sure that you don't include the endocardium. So when you are tracing, you trace like this, and it's going to calculate, take into consideration the area. This is the planimetry method. It's going to do that. It's going to calculate for you, and this will be your end diastolic volume. So it will consider the volume of this chamber in diastole. Then you come to your systole. Again, you trace. Don't include the endocardium or any other structures within there. So it will give you something like this. So the moment you are going to press or finish doing this, it's going to give you your ejection fraction. Your ejection fraction. And this ejection fraction, you are going to see that it's going to show you the EDV and also the ESV, which is the end diastolic volume and the end systolic volume. So just by doing this, you are going to have your ejection fraction that is more quantified, because it's going to take into consideration the volumetric aspect of it. Some other machines, they actually call it ejection fraction by volume. It's very important in most cases when you're giving your report to also give ejection fraction done by volumetric assessment. This is very important in cases where you are having regional abnormal wall motion, because it's going to give you a quantified method of doing it. So what is the take-home message for the Simpson method and also the TEC method? The Simpson method is that you need to assess the 2 chambers, one in diastole, the other one in systole. And this is how you check. Make sure your mitral valve, you check your frames where the mitral valves are closed, and you also check in another view where your mitral valves are open. And then you trace. Once you finish the tracing, in other machines, you can pull this up to here. In other machines, you are going to see that this is going to be traced or automatically be calculated, and you're going to have your ejection fraction. While in the Simpson method, you also have to consider that you don't trace or include other structures that comes into the chambers. Another method that you're going to make sure that you pay much attention is the technique and the view, and also your plane in which you are cutting your methods that are coming into place. So the major echo parameters that you need to take note is the ejection fraction, which is the amount of blood that is ejected out of the left ventricle per minute, and also you consider the fraction shortening, which is the contractility of the left ventricle of the myocardium, and it's calculated as a percentage. The ejection fraction is 55 to 70, depending on the guidelines you are using. And also the fraction shortening is 25 to around 45%. So these are the methods that are used whenever you are doing your ejection fraction and assessment of the left ventricle function. I've already talked about the views. The views are very important. In the other one, you use the apical 4-chamber, that is in the Simpson method, and then in the other one you use the plaques, which is the palestino long axis view. Very, very important. So these are the parameters that we use for. We go straight into how to assess the right ventricle systolic function of the heart. This is also another area that we also need to take part and know exactly what is happening. So number one, you are going to see that the assessment of the right ventricle systolic function becomes very handy. And once we understand some of these parameters also, it becomes very easy to pick the parameters. I'm going to do this. So for the right side, it's also very easy. Very, very easy. This is our left ventricle. This is our right ventricle. This is our right atrium. This is our left atrium. So when you look at this apical four-chamber, by the way, sometimes we refer to the right side of the heart as the forgotten heart. Why? Most of the parameters are done on the left ventricle, and we tend to forget what is happening on the right side of the heart. Yet, it's also another important parameter that we need to take into consideration in cases where you have the right ventricle is failing and also the left ventricle is failing, which sometimes we may refer to the biventricular failure. So when you are having a biventricular failure, this becomes very key. It means both the right and the left side of the heart, they are failing. So the method we use to assess the contractility or the contraction of the right side of the heart, it's called TAPSE. Okay, this is abbreviated as TAPSE. Now, what does TAPS means? TAPS means tricuspid annular plane systolic excursion. Tricuspid annular plane systolic excursion. So meaning this method, we need to use our scan line. You just get your M mode, you put it on the annular side, the lateral side or the annular side of the tricuspid. This is where you put your line. Make sure it's perpendicular and aligned along the annular. And this is where the tricuspid annular, so tricuspid and annular plane, this is the plane, and it's at the annular. So tricuspid, annular, and the plane, it's in this plane, and then systolic excursion. So what is happening here? Remember, you are having, when your ventricles, they're in systole. When the ventricles are in systole, when it contracts, it goes up. So there is a bit of movement going up and down. During systole, it goes up. During diastole, it comes down. That is the annulus. We are discussing the annulus. So the annular motion here, during systole, it goes up, and during diastole, it comes down. So these movements can be recorded by M mode, and it's going to give you something like this. So this cliff that we are having, this cliff, it's basically telling you that this is systole, this is diastole. This is systole, this is diastole. So this is the peak. This is a peak. This is the systolic excursion. This is the systolic excursion because during systole and then diastole. During systole, again, this is the cliff or the peak. So in conclusion, we can simply say left ventricle systolic function becomes very key when it comes to the assessment of the heart. The reason is very simple. There are specific things we have to consider. Number one, we have to know that this left ventricle systolic function has to do with the contractility of both the right ventricle and also the left ventricle. Number two, we also have to make sure that there are two methods that we use to assess the left ventricle and the right ventricle. One is the Simpson method. The second one is the Teck method or the biplane method. The biplane method, this is where you use the M mode to assess and measure the right ventricle using the M mode. And remember, we said the M mode also helps you to measure or assess the cardiac cycle and also the dimensions. So under dimensions, it will help us to quantify the thickness of the intraventricular septum in systole and also in diastole, and also quantify the measurements of the left ventricle internal diameter in diastole and the left ventricle internal diameter in systole. The difference between the end diastolic volume of the left ventricle in systole and also the left ventricle internal diameter in systole also helps you to calculate the function part of the heart, and it's going to give you the ejection fraction, which we define that the amount of blood that is ejected out of the left ventricle per minute. And that's what we are referring to as the ejection fraction. This is very important. The normal parameters should range from between 55 to around 75%. This is also very important to consider when you're using other guidelines, which can be around 50 to around 75%. After doing that, you also have to make sure that you consider the Simpson method, which is another method where we use the volumes to calculate the contractility and also the relaxation of the left ventricle. It's called the Simpson method because we also take into consideration the barometric aspect of it, where you have to trace the chambers of the right ventricle in systole and chambers of the right ventricle in diastole. How do you make sure that this is in systole, this is in diastole? You consider the mitral valve in systole when they are closed. You also consider the mitral valve in diastole when they are open. When you are tracing, you have to make sure that you pay attention to specific structures that are not included within the calculation. So immediately after you finish your biplane tracing, both in systole and diastole, the machine is going to calculate automatically the ejection fraction, and it's going to give you. Very important to remember that this Simpson method is very reliable when you are having regional abnormal wall motion. Why regional abnormal wall motion? Because when you are using your TEC method, sometimes you may not find and have your systolic thickening, which may be very difficult for you to actually calculate your ejection fraction. So thank you so much for this. And then I also talked about the right ventricle systolic function, where you have to use TAPSE. We define TAPSE as the tricuspid annular plane systolic excursion. This is where you use the systolic excursion, where you put your M mode on the free wall of the lateral annulus of the tricuspid, and then you see the movements of the annulus both in systole and diastole. And then we said normal should range at least more than 17 millimeters, and this tells you that the right ventricle systolic function is normal. So thank you so much as you enjoy your left ventricle systolic function assessment lecture. See you.